The following is a special video presentation of the Hennepin County Library.
Hi, welcome to a discussion with Dr. Pennywise Budoff. I'm Bruce Southworth, a book reviewer for Publishers Weekly and Druid Review of Mysteries. Dr. Budoff is the Director Emeritus of the Pennywise Budoff Women's Health Center in New York. She's conducted considerable research in the areas of menopause, menstrual pain, breast cancer, osteoporosis. She's the author of two books, No More Menstrual Cramps and Other Good News, and No More Hot Flashes and Other Good News, which have been out a while, I understand. She's an assistant professor of obstetrics and gynecology at Cornell University, and she's the chairperson of the Board of Consultants who recently issued the PDR Family Guide to Women's Health and Prescription Drugs. Welcome, Dr. Budoff. It's a pleasure to have you here.
Pleasure to be here.
Let's start out by talking about the PDR Guide. This book is a sort of a summation of a lot of current women's health issues. It's divided into sections, rather like the PDR. I suppose we better define that term, physician's desk reference. It's a common.
The physician's desk reference is a very large reference that you wouldn't want to have to pick up and carry around, but your doctor has it. Every doctor in this country has it, and it really helps us prescribe drugs for patients. It tells us what the drug does, what are the indications for it, what are contraindications, what are side effects of the drugs, what the drug will mix with, won't mix with, when to use it, when not to use it. And every physician uses this every day in his or her work. This is an offshoot of that book, and it is the PDR Family Guide to Women's Health. And basically, the last half of the book, and there are nearly 900 pages in this very heavy book also, but a very good book, on drugs, how they work, how to take them, what to do if you miss a dose, what they do mix with, what they don't mix with. Similar to the PDR, but very reader-friendly. And the first part, of course, is the 41 chapters on different aspects of women's health. Yes,
it has quite a few chapters on breast cancer, fertility, infertility, sexually transmitted diseases. And on top of that, it also has a section which people can help identify certain drugs and dosages that they've got. Perhaps we can show that.
Right. They're wonderful color pictures, and I think they're very helpful. Sometimes I think patients will go to the drugstore and say, did he give me the dose I used to get? Is that the same thing? Or did he give me a generic and I pay for the real stuff? And patients want to know, and they deserve to know. Or they're worse. Once in a while, patients come in with a bottle with about 5 different medications in it. And they're not quite so sure what that one pill was supposed to be.
I'd be unsure of the 5.
Yeah. So anyway, we can look it up and make sure.
Yeah, that's I think one of the very, very handy things in the book is people to be able to say, oh yes, this is what this is, or I recognize that.
Yeah, I think color illustrations were a real plus. And of course, doctors have that in their PDR. And we need that too.
How was it decided what kinds of things to include in the book? I
think everything that really is important to women's health is really in the book. It covers the gamut from young women and young women's problems such as eating disorders, anorexia, bulimia, contraceptives, sexually transmitted diseases. These all affect young women. They also, of course, affect older women too. Mustn't forget that. And my older patients, I caution and say, remember, remember to use condoms, no matter what, even when they're postmenopausal, if they have a new partner. Other than that, it goes through infertility, and then it goes through things that affect women of all ages, such as depression, which is actually something that affects younger women more than older women.
Really?
Yes, and I think that type of thing is not really well understood by women. Women kind of think, golly, menopausal women, they're going to be depressed, and it's not true. They're less depressed than women in their 20s and 30s.
Why is that? Is that because
Well,
of some of the
maybe because
changes?
life has just gotten more settled for them, and some of the things they finally worked out, and maybe life situation's better. The kids have kind of grown up. Money's better. Who knows? And maybe part of it is chemical too.
Staying on depression for a moment, I guess, what would some of the in this younger age group, what was some of the causes of depression? How do you tell, let's start there, how do you tell the difference between an actual depression that should get treated versus when you're just feeling down for a day or two because things have just gotten too much?
Right. Well, down for a day or two, you know, feeling not too good, you didn't do well on an exam, or your boss was not too terrific to you over lunch or something, that's normal. If someone dies in your family, someone that you love very much, that you're close to, you're going to be down, you're going to be sad, and that is normal. Actually, it defines depression in the book, which I think is very helpful. But depression is feelings of sadness and hedonism, which is not getting pleasure from life, not enjoying things, not being able to smile. Over long periods of time, maybe more than 6 to 9 months after a loved one has died, then we begin to say, you know, much of the mourning process should be over. It's time to feel better. There are many things in life that cause normal depression. People don't think about them. Divorce and death, of course, are right up there. But moving is a major stress. Probably the second most stressor after death of a spouse, believe it or not, because there's so much stress and uprooting of everything that you're kind of used to, and then having to go to a new environment. So people who move also may get depressed.
I'm kind of getting the impression that within depression there's a lot mixed in, stress and fatigue.
Right.
I know there's something chronic fatigue syndrome, which I don't really know that much about, but they seem to be pretty well intermixed in sorting out what's what.
Well, you know, depressed people find it very difficult to make decisions. They do feel tired and fatigued. They can't make decisions. Get up in the morning. Even, what am I going to wear today? Becomes difficult because the mind has almost like slowed down. I mean, we think of things like crying and just being out of sorts type of thing. And then, of course, there's that, is it PMS or is it depression? And if the definition is PMS, premenstrual syndrome, it has to occur a week or so prior to the onset of your period. But you have to have a week or 2 weeks within the month when you feel normal, when you feel good. There are women who will come into the office and say, I have PMS. And when I finish talking to them, they're just plain old depressed. They don't have PMS.
Now, what's some of the most common treatments for depression? How do you treat something like that?
Usually a mixture of a psychiatrist or a psychologist or a clinical social worker doing therapy. And now we have many, many drugs that are very helpful with very few side effects.
One that I've heard of is, if I pronounce this correctly, amytryptyline.
Yes.
Or Elavil, I think is the proper name.
That's actually one of the older drugs. And the older drugs, one of the problems, they're very good, mind you. And a specific person, when you begin to treat them, you really don't know what drug is best for them. It's like treating a patient with arthritis. You're not quite sure, although the drugs may be quite similar, which drug is going to work for this patient. So if you have a depressed patient, you may start out with one type of medication, and you might have to move on to another. We now have some of the SSRI, they're called serotonin reuptake inhibitors drugs. And they're the things like Prozac and Paxil and Zoloft. Actually, they have less side effects than the drugs like amitriptyline. They have less of the dryness of the mouth and constipation problems that we see. But so because they have less side effects, we often tend to use them first. And family doctors can use those drugs. You don't have to be a psychiatrist to use them. They work very well.
Should someone who's been on a particular drug, an antidepressant, for a very long period of time review that periodically with their physician and say, should we
Yes.
update to something that's newer, or?
Well, it depends. If you're doing well, you can leave your medication as is. Sometimes medications, as you're doing better, can be lowered. It doesn't mean that you're going to be on this drug forever, because hopefully during this time you're going to be able to work out your problems or whatever is bothering you. Depression, of course, can be endogenous. It's kind of something that wells up from within, but there's usually something that's caused it. In fact, we're beginning to know now that some women who are depressed also have been abused as children and maybe didn't really recognize it, never dealt with it. These are things that you really have to sit down and talk to your doctor about. Anger is not well expressed by women. Women tend to not punch somebody or kick the dog or the cat. We've not been brought up that way. So
Everything's internalized, which
right. So men
creates
tend to
stress.
deal with anger much better than women, or men go out and drink. But you know, these things are not so socially acceptable for women.
But becoming to be not so socially acceptable for anybody these days.
That's
the
right.
drinking.
But women, we feel, tend to internalize these feelings, and therefore take the anger, turn it inward, and become depressed. So if we can find out what are the things that maybe women should have been angry about, and get them out into the open by talking with them and being able to get into whatever the things are that are bothering them, then very often these women feel better and they can go off everything.
Now, you've been one of the early proponents of self-education, patients self-educating themselves and getting
Yes.
second opinions and so on. Was it these kinds of issues and trying to understand the specific causes, for instance, of depression in women that prompted you to found the Women's Health Center?
Well, I founded it's called the Pennywise Budoff Women's Health Services. We're now affiliated with North Shore University Hospital on Long Island. But I founded the center back in 1985 because I felt that women were getting fragmented health care. Because of a woman's anatomy, she's divided into the GYN area and then the rest of her, the internal medicine area. Basically, I'm a family doctor, so I always saw my patients and did their physicals from head to toe, and their psyche too. But I found that most women got their health care from gynecologists. Well, that's fine if you're 20 or you're 30 and you're really healthy. But once you get maybe to 35 or 40 or, I mean, even older, you could be 50, and maybe you have a health problem, maybe you have high blood pressure, then you really need to be under the care of an internist. Now, why you have high blood pressure? Maybe because of something the gynecologist did. He may have started you on, let's say, oral contraceptives. Or maybe his history is really important to know. Did your high blood pressure start all of a sudden? Or has it just been kind of getting up there over many years? Now, the internist doesn't have access to that, but he should. And getting the two doctors to change records and talk to each other is very difficult. So what I did is I started a multidisciplinary or multi-specialty center with gynecologists, family doctors, and internists. So right now we have 4 OBGYNs and 2 family doctors. We have 2 endocrinologists and a gastroenterologist and a cardiologist and full-time x-ray, and we do bone densitometry, of course, because we have a lot of interest in menopausal women too. But I think it's a very special center, and some of the women's magazines agree. And one of the first in this country, and it's been the model for many that have developed since. Many hospitals and private physicians have been through and modeled their centers after it.
That must be particularly rewarding to know that the approach is being taken and accepted and
it is, and sometimes a woman can come in and actually be seen by 2 physicians, get her mammography and an ultrasound, whatever needs to be done, and then we can kind of put her all together that day.
So you get
that's special.
A big picture of, the
Right.
total health picture as
Right.
opposed to just, as you say, the fragmented nature of everything.
Right, and for that reason, actually, we do see patients from quite far away because they can get so much done and have it all kind of put together by one person. It may be the gynecologist talking to the internist, but they'll both sit down and talk to this patient, and then everything will be kind of all put together on one chart.
That's great. I mean, that seems to make such,
It makes sense.
Very
and
common sense.
I think that this may be one of the ways that women's health, the problem of women's health, how do we actually get good women's health, can be gotten around. In other words, rather than starting a lot of women's health residency programs, which are going to be very difficult, I think something like this is a great way to do it.
What about just the general nature of research into women's health issues? As I understand, women's medical issues haven't been as highly researched or as deeply researched as men in the cohort group to understand exactly what's going on. A recent study was talking about how good a drink or two may be for you, and it turned out that there were no women in that group.
Right.
And someone that I was listening to, an interviewer, pointed out that a drink or two may not be good for women because it increases their chance for cancer.
Right, for breast cancer. That's right.
So, how is there a real movement? You've done some of that kind of research, but is there a movement in that direction?
There is a movement.
So there's hope.
And it has to be because the women aren't going to put up with this any longer, basically. But I think years ago, when many of these studies were set up, there was the fear of a woman being in a study, taking a medication, and becoming pregnant or being pregnant. And that was a problem. And then the drug company said, well, maybe a woman will metabolize this drug differently if she's premenstrual. And if we study her then, maybe it's going to really botch up things, because maybe when she's in the middle of her cycle, the metabolism may be different. And of course, they're right. It is. And I mean, just even looking at alcohol, we know that women, when they're premenstrual, tend to get drunker on less alcohol. So there are differences, sure.
It's very. Are there? It just made me think. Are there then also differences in, say, maybe common medications that the effect might be completely different, or at least radically different on a woman than in a man?
I think that can be true. And most women, of course, tend to be a lot smaller than men. So, I mean, do you treat a 250-pound man with the same dose that you do a 90-pound woman? Actually, no, you don't. And these are things that doctors have to consider. Not with every medication, maybe not with things like maybe penicillin, although that may not be true. My husband is about 6'5", and when I treat him, I have to think about that too, what dose I'm actually going to use for him.
That's exactly what I was kind of thinking of, some of the things that might treat common infections or various antibiotics and so on. I would think that people would react
and of course,
differently.
For very sick patients who have to be in a hospital, who you're going to give IV drugs to, those IV drugs actually are often administered by weight. So we need to know patient's weight.
You need to know patients, so just how much the body can absorb and tolerate and so on. When is it a good idea for women to kind of do a lot of self-diagnosis? I mean, there's a lot of very good descriptive information in the PDR guide. If you have any tendency toward being a hypochondriac, I would think you'd end up calling the doctor and say, I've got to get in, I've got this dread disease. But is there a point at which self-examination is not a good idea that you should, how do you determine when to go to a doctor and when not? And
I think it depends on what the circumstances are. I mean, everything is very individual. Some patients have had things already many times, so they recognize it and they know what it is. Now, there are many of the over-counter yeast treatments for yeast vaginitis, and that's fine. If a woman has already had a yeast problem, has been to her doctor, he's diagnosed it, she gets those symptoms again, then she can use the over-the-counter medication. But on the other hand, to have never had the problem and go out and use it for the first time probably isn't such a terrific idea. What we especially, I think, have to be careful of are women who may be in new relationships and may be at risk for some sexually transmitted diseases. Figure, I have something I'm uncomfortable, I'm going to go use one of the over-the-counter products. That's not such a terrific idea. One of the problems, of course, with sexually transmitted diseases is they cause no symptoms. Now, I know everybody thinks, oh, I know I'm going to have symptoms if I catch something.
Mm-hmm.
That's not true. And then the other tendency, of course, is to blame the male. He should have told me, he's a rat fink.
Mm-hmm.
Sorry. But the truth is, many men have no symptoms. They have much less in the way of symptoms than women. So they really innocently may infect a woman.
Mm-hmm.
And of course, we have to say a word about condoms here. And I tell, again, my older patients and my young patients, even if you're on a birth control pill, even if you've had a hysterectomy, if you are not monogamous, if you're with a new partner, at least until you know that he's a partner you're going to stay with, he must use condoms, and you have to insist on it.
Yeah, it's just that, again, is
I mean,
another-
we didn't even say the word AIDS, but it's out there,
Mm-hmm.
and it is certainly being spread to women, and women are at much higher risk than men
For infection, really.
for infection. In other words, a woman will be infected much more readily in a relationship by an infected partner than if she were infected and he were not.
Well, that's interesting.
He's less likely to pick up the AIDS virus than she.
Is that true also with some of the other sexually transmitted diseases?
Yes, it is.
What,
Has to do with the anatomy.
yeah. I mean, I'm kind of wondering if at the point where you say, it's since the symptoms aren't particularly obvious,
Right.
What would you begin to notice that flagged your mind to say, I think I'd better go talk to a doctor? What would
Well,
some of the things?
it would be any feeling of, I think any feeling of anything that wasn't normal,
Okay.
especially if you haven't used condoms and you are not in a monogamous relationship.
Okay.
I would say that's all you need. I mean, because there are so many different symptoms, whether you're talking about herpes, whether you're talking about chlamydia or human papilloma virus. And then the problem is that left alone, some of these diseases, which may cause almost no symptoms, can lead to infertility,
Mhm.
chronic pelvic pain. So women must be very vigilant,
It really
very
sa-
careful.
It sounds like one of the very strong underlying messages in all of this, and not so underlying, is that women have to really kind of take charge of their own health,
Absolutely.
insist on the things that
That they know are right.
are going to protect them, and
Right.
see the doctors when they're, and
Right, and that's right. And be vocal also with their doctors, and make
Mhm.
sure that you tell your doctor.
Yeah.
There are women who still feel very reticent about saying something
Mhm.
about a partner
Mhm.
or a new partner. But, doctors are not mind readers.
Yeah. there's-
Sometimes we think they are, and that's wrong. And if you don't tell your doctor, he may not look, or he may not order the tests that are truly important. So you have to have a doctor, first of all, that you're comfortable enough with to talk to, and they need to know.
What about the sort of day-to-day taking charge of your own health,
Mhm.
vitamins, that sort of thing? Now, you're on a particular vitamin regimen, as I understand. What kinds of things are you taking?
Oh, I take a multivitamin mineral calcium preparation because I believe in across-the-board vitamins. In other words, I think if you just take E
Mm-hmm.
or C or a B complex, I think things kind of get out of kilter. So I think it's really important that women take a preparation that is really for them for their age. And, women need calcium from their teen years on.
Mm-hmm. Doesn't that taper off after
No,
the time?
actually, the need actually increases. We only build bone until we're about 25 years old,
Mm-hmm.
or maybe 30. And that is bone in all over the body, including the hip and the spine.
Mm-hmm.
After we build our bone bank, we tend to decrease our bone because we're constantly stealing from this bone bank. And of course, we lose bone at a very, very slow rate as we age. But then at menopause, we can lose 2 to 5% of our bone each and every year for about 3 to 5 years. So, I mean, if you're a fast bone loser, you could lose a quarter of your bone, 25%, just in 5 years. So, one of the problems is that women don't have enough bone to begin with. So, in order to do that, you need a good calcium. Women should take 800 to 1,000 milligrams of calcium as young girls. Now, that means that you have to drink your milk, have your yogurt, your cheeses, many things that women won't do because they're always worried, unfortunately, about how they look and what their weight is, okay? Or some women actually are lactose intolerant and cannot digest milk and milk products well. So that these women really need to supplement, and most women do have to supplement. The other thing is that you asked me what I take. I take a product called Bone Form, B-O-N-N-E, Form, F-O-R-M-E. They're vitamins for women, and they come in an over 40. But in it is everything I need, including 1,000 milligrams of calcium, and you need 400 units of D, because as we get older, the D helps us to absorb the calcium. And some women, as they age, especially when we talk about more elderly women, if you don't have the D, you actually don't absorb it. And everything else is in there. And they're one of the 800 number for the vitamins that you can just call and get information. But anyway, it's also important to know that calcium cannot be taken all at one time. Women over the menopause age need 1,000 milligrams of calcium. You just can't take it all at one time. It's no good for your kidneys. It's too big a load. So you need to divide it up. And the best way actually to take it is 4 times a day, after each meal and at bedtime. Always take vitamins and calcium after food. And that's actually how they're made up too, the ones I take.
That's interesting. Would you recommend that before starting even a vitamin regimen that women talk to their doctor and get a better picture of the kinds of things that at their age, their weight, that they might be deficient in? Or is just an over-the-counter multivitamin?
It's not possible. It's really not possible because doctors don't know enough about it. And we also, I think, don't know enough about vitamins and what we actually get in our own food. We don't know how long it's been in the field. We don't know about the earth, where it was grown. We don't know how long it sat in the, well, think about it, in the supermarket.
It's true.
How do we cook it? How much do we lose? I mean, or has that orange been in cold storage for the last 6 months?
Yeah.
We don't know that kind of stuff. No one actually ever talks about it. I would like to do some research on that.
It sounds like it would be very interesting.
Yeah, I think it would be very interesting. I really do. The book also goes into vitamins and nutrition and how important it is and exercise. And of course, it has about the 4 or 5 chapters on menopause, including the one on osteoporosis, and then about hormone replacement. And I like the book because it talks about all the things you can do, kind of across the board. Many women, when they go to their doctor, find that they're faced with one drug because the doctor knows that drug best of all, and that's all he uses.
Okay.
But that one drug might not be the drug for you. Okay. Or maybe you shouldn't even take an oral. There's a patch available.
Sounds like the one thing that we need to do from this is have women self-educate themselves, use this as a reference, and see their doctor.
Right.
But we've completely run out of time. I don't know where it went.
I can't believe that.
Doctor, thank you very much. I appreciate it.
Pleasure.
And tune in again for another discussion with. Thank you.
A presentation of the Hennepin County Library.